bit, it is likely that a pulmonary rehabilitation program will have more impact. COPD. What is the next most appropriate step in management? Immediate intubation and ventilation, intravenous doxapram, BiPAP, increase inspired oxygen concentration, and CPAP. 76-year-old man with a 10-year history of chronic obstructive pulmonary disease was admitted to the hospital with the 2-day history of progressive worsening dyspnea and a cough productive of mucoid sputum. His wife states that he is on home oxygen therapy for up to the 12 hours per day and home nebulizer. He is breathless on the minimal exertion and rarely leave the house. He has severe exacerbation per year requiring hospital admission, and these have become more frequent over the last few years. Although he has never required ventilation perfusion, he has stopped smoking 2 years ago. On examination, he was acutely dyspneic with a respiratory rate of 32 per minute and was using accessory muscles of respiration. He was epirexial, pulse of 120, regular blood pressure of 182/92. He was able to speak in broken sentence, and auscultation of his chest revealed the generalized poor air entry and the widespread expiratory wheeze. The chest radiograph is shown below. ABG pH of 7.32, it's low, and the PO2 of 6.2 low, and PCO2 is 7.2 high. CO2 retention is there, and secondary respiratory failure. And his inspired oxygen concentration was increased to 28%, and he was treated with intravenous hydrocortisone, salbutamol, ipratropium nebulizers, and aminophylline infusion. After 1 hour, he had made a little improvement and was tiring. pH is fall down 7.26, and PaCO2 is retained 9.2. Now BiPAP. This man is in type 2 respiratory failure due to the severe exacerbation of the chronic obstructive pulmonary disease, COPD, and is not improving despite the maximal medical therapy. Non-invasive ventilation is the best option in this situation and may be life-saving. BiPAP has been shown to reduce the respiratory acidosis, increase clearance of the secretion, and re-expanded collapsed lung segment. However, it is only suitable for the patient who are conscious, cooperative, and able to protect their airway. Okay, conscious, cooperative. If the GCS will be 13, then it will be used or not?
No, NIB less time. Ventilation.
Like a patient with COPD and having CO2 retention, okay? And GCS is around 13. Then we go for BiPAP or not? Directly intensive ventilation. What will be the management? PD related to smoking, asthma, cystic fibrosis, bronchiectasis, and alpha-1 antitrypsin deficiency. 31-year-old woman presented to the respiratory outpatient department with the 3-year history of increasing shortness of breath and cough. She had required numerous courses of antibiotics in the last few years. She was a smoker of 5 per day and for 5 years, but gave up 4 years ago. Respiratory examination revealed a hyperinflated chest and mild wheeze throughout. FEV1 by FBC ratio is 50/80%, and TLCO is 68%, KCO of 71%, RV by residual volume by TLC ratio increased. TLC total lung capacity decreased.
Patient has obstructive feature and low KC. Low KC also. Yes, alpha-1.
And smoking history is very low if you suspect, and COPD is not a cause. Yeah. No, smoking history is very fine. Like very little. He gave up 4 years back. Alpha-1 antitrypsin deficiency is rare autosomal recessive disease associated with the development of the premature panlobular emphysema. Most severe in the basal areas of the lungs. Emphysema is thought to result from an imbalance in the lung between the neutrophil elastase, which destroys the elastin, and the elastase inhibitor alpha-1 antitrypsin, which protects against the proteolytic degradation by elastin. The decline in the lung function is accelerated in the smokers. Patient usually present with the progressive increasing shortness of breath and the weight loss. Cor pulmonale and the polycythemia occur later in the course of the disease. A chest X-ray usually shows the bilateral bibasal emphysema. Lung function test and the obstructive picture, and the RB/TLC ratio is raised, indicating the gas trapping. Transfer factor will be reduced. There are the number of the different phenotype depending on the serum level of the alpha-1 antitrypsin. Like PI is the protease inhibitor, M normal allele, S and X have null or disease alleles. Phenotype alpha-1 antitrypsin level disease. PIMM normal. Okay. PIMM normal, PIMS 80%, PIMZ 60%, PISS 60%, PISZ is 40%, PI null that nil, and premature emphysema in ZZ, and SZ is the liver cirrhosis, premature emphysema. Okay, pizza is bad for health. Treatment is okay. Treatment is similar to that of asthma. Alpha-1 antitrypsin replacement can be given weekly or monthly, and is recommended for those with very low serum levels and abnormal lung function. Lung transplantation should be considered in the advanced disease. Patients should be encouraged to stop smoking. Which of the following antibiotics would be most suitable in the first line treatment? Pseudomonas aeruginosa in their sputum for the first time. This is associated with deterioration in his breathlessness. IV ticarcillin plus IV gentamicin, ceftazidime, and IV...
Ceftazidime. B. Ceftazidime, antipseudomonas.
It is third generation or fourth generation?
Ceftazidime. Third.
Yes. A standard treatment is with the third generation cephalosporin such as ceftazidime, meropenem, or aztreonam, used in combination with gentamicin if required. Pseudomonas aeruginosa is resistant to amoxicillin. Ticarcillin is primarily used against the urinary pseudomonas infection rather than the respiratory infection. IV colistin is effective antibiotic against the most gram-negative bacilli. It can be used as a last line treatment against the pseudomonas. IV colistin. Klebsiella and the Acinetobacter infection in the presence of the multi-drug resistance. It is generally not used due to its renal toxicity. This makes it inappropriate at this stage of this patient. Which of the following features might point toward Legionella infection if found in this patient?
Transaminase elevated.
71-year-old man returned from the veterinarian's convention in Spain. A few days later, he becomes unwell and with high fever, rigors, dry cough, and severe headache. On examination, his BP is 105/60, pulse of 92 and regular, and his temperature is 38.9. The evidence of the left basal consolidation, dullness suggestive of the pleural effusion, and his oxygen saturation is 93% on air.
But best answer is Spain.
Pardon?
Best answer is Spain. Europe is Spain.
And now is Omicron. Yeah, what is happening? We are end with the virus. Human race will dead. Virus will end us. Or we will take more vaccination. Legionella has a incubation period of 2 to 10 days and presents with the fever, rigors, headache, myalgia, dry cough, progressively increasing respiratory distress and confusion. Diarrhea and vomiting are common, as are the non-specific liver function test abnormalities. Relative bradycardia may be seen in the some patients in contrast to the other acute pneumonia. I remember list of the Dr. Bora sent it to us. Relative bradycardia. Pleural effusion may be seen in the up to the 50% and chest X-ray appearance may take us to 4 months to return to normal. Diagnosis is made with serology or with the PCR or on the urinary Legionella antigen. Treatment is with quinolones as first line therapy with the macrolides as a potential alternative. Complications include pericarditis, encephalitis, and kidney disease.
Yes, most of the they are giving the first line is macrolide. Written is. Maybe
what is the criteria for that? There is a criteria like severe disease quinolones.
Quinolones. Mild to moderate.
Dr. Boris said. How to say that? Okay, pneumonia if more or what? Severe one. 68-year-old retired teacher present with the 3-month history of recurrent hemoptysis. She had not sought medical advice at the first as it had only been tiny, but the last few times there was a large amount of blood which alarmed her. She had also noticed a persistent cough with some malaise and weight loss. She had a past medical history of tuberculosis. With the age of 19, she was an ex-smoker who stopped the 15 years ago and did not drink alcohol. Physical examination was unremarkable. Chest X-ray shown below. What is the most likely diagnosis? Yeah. What is the management?
Yes, surgery.
If it is stable, then go for that lobectomy, and if she will be some underlying disease, comorbidities, then go for that. Yeah. Embolization. No, embolization. Which of the following represent the best initial step for this patient? 46-year-old man present to the persistent dry cough and shortness of breath. There has been a history of fatigue over the past few months and has recently lost his job. On the examination, there is a diffuse crackles on the auscultation of a lung field. He also has a nodular rash on his seam. Chest X-ray reveals the bilateral hilar enlargement. There is a diffuse increase in globulins. Which of the following represent initial stage? What is the stage? I think it is stage 1. Diffuse crackles, okay. But X-ray just bilateral hilar lymphadenopathy.
Hilar lymphadenopathy and infiltrate, diffuse crack. Yeah. This is infiltration, so it is stage 2.
Yeah, crackles, diffuse crackles.
Yeah, so 2, 3 is.
Yeah, and that infiltration not seen on the X-ray mostly. Yeah.
Mostly, yes.
Bilateral plus hilar lymphadenopathy.
So 2, 3 is indication of steroid.
Yes. From these results, which disease do you suspect that C is the most likely to have? FEV1 of 0.3 and total lung capacity of 6.8, corrected transfer factor 3.4. It's low and total lung capacity 6.8 on the higher side. FEV1 of 0.3. You are seeing a patient in the clinic. Unfortunately, all the clinic notes in the cardiorespiratory test department are being audited. However, the patient brings along a copy of her lung function result. Her date of birth is missing from the report. Okay. From these results, which of the following is suspected? Total lung capacity on the higher side, okay, and the APP
PCR
and the
low.
0.33.
What is the last option? COPD. A.
COPD is defined as a reduced FEV1 by FBC ratio, where the FEV1 is expired volume in the 1 second and FBC is the forced vital capacity, such that FEV1 by FBC is less than 0.7, though you are not given an FBC reading. Note that the total lung capacity here is within the normal range, yet FEV1 is significantly reduced. This fits best with the diagnosis of COPD. What is the most likely diagnosis? Mesothelioma, bronchogenic carcinoma, lymphoma, inflammatory effusion, tuberculosis effusion, chest X-ray, extensive right-sided pleural effusion, cytology, no malignant cell seen. 61-year-old male present with the history of dull aching right-sided chest pain, cough, and unintentional weight loss. He has a 50-pack year smoking history, recently retired from the working as a plumber, where he feels he is likely to have been exposed to asbestos through his working life. He also has a history of rheumatoid arthritis, which is currently managed with the NSAIDs and the methotrexate. However, he remembers having an intravenous treatment in the past. On examination, he has a BMI of 20 and dullness to percussion on the right side of the chest, and hemoglobin of 11.5 with its lower side, WBC of normal, platelet normal, sodium on the normal side, creatinine 130 little bit high, glucose of 7.2 higher, pleural fluid LDH is more than 300 and pleural fluid protein is more than 30. Lymphocytes of more than 1240, 50, glucose of 3.4, and cytology, no malignant cells, and the extensive right-sided pleural effusion.
Patient has exudative pleural effusion.
Yeah, pleural fluid protein is more than 35.
Plumber.
It is more than 35. Okay.
30.
Yeah.
30, more than 30. More than 30. A. Mesothelioma.
Okay.
Patient lymphocytes is also missed. Lymphocytes is.
I was thinking something, but few people are.
Glucose also low, I think. Patient.
Yeah,
Fluid glucose.
pleural fluid glucose is low here, 3.4. Blood
Half.
glucose is 7.2.
Less than half. No, actually, we are this plumber. Huh? They are giving the plumber.
Yeah.
They beat this.